These are the things that you have to notify, that from this prior section you get the information. That can be a very good question out of it. See, an acute gout attack may mimic cellulitis. So we got the DDs for acute gout, cellulitis, okay? But usually in cellulitis, joint mobility is usually preserved. Patient, when it comes with cellulitis, it is gradual. It is not an acute thing, and they can move their feet, okay, unless it overlaps a joint. So usually they can move their feet, okay, they can move their joint, the involved joint, okay. And but in gout, it's so painful. I tell you, I've seen patients, they cannot move their joints at all. So risk factors, again, very, very important. Just go through this part section here. So precipitants of gout. Drugs are fact. So furosemide, aspirin, so low dose, alcohol, cyclosporin, and thiazide diuretics. So that is called a fact. Okay. So these are the drugs that can precipitate the gout. Now foods are salt. So these are seafood, alcohol, beer, and spirits. Liver and kidney. Turkey is meat. Okay, so this is called salt. So remember, you can remember this whole scenario by making a scenario. Okay, so let us believe that there is a guy who is from affluent society, who is alcoholic, who takes a beer, and who takes only protein. They have expensive dinery, and they go and take turkeys, and they're taking food that has salt. Let's say they're on lots of fast food maybe. Okay, so they can have flare-up of this. And also let's say this patient that we're talking about is an obese patient, and they have hypertension, so they're taking furosemide. So, and also they are immunosuppressed, they're taking cyclosporin for those conditions. And also when they have the flare-up of disease, they're taking aspirins because they didn't know that this was gout. So all of this actually comprehends these precipitants of gout. That's how we can remember it. Okay, so we just go to the example, and then you don't have to say, oh, what was it? Was it thiazide? Was it furosemide? Was it blah 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 blah? So you can just think about it. You can learn it by heart by looking at making a scenario like that. Okay, also remember that the aforesaid person, if they have a renal failure condition, if they have a condition that is they're obese, so they can have a renal failure, they can have a metabolic syndrome. So all of this can precipitate to the gout. So clinical presentation, we've talked about it. There will be acute flare-up. So joint swelling, severe pain, erythema, joint mobility is limited, and attack will subside spontaneously within days to weeks, so 5 to 10 days, but may recur. So patient can come to you, they can say, okay, I had this, but after 5 to 10 days it was gone. I'm feeling okay now, but it may recur. So you have to investigate, you have to inquire about it further. And also there can be tophi. So tophi is a sign for chronic gout. Okay, so it lives on the signs that, okay, the gout is still there. So where would you find the tophi? This is a very typical signs. First MTP, ear helix, olecranon bursa, and tendon insertions, commonly in the Achilles tendon. So any patient who has come that they're saying, okay, I'm having severe pain when I'm trying to lift up my feet. That can be a hidden gout on there. And also another chronicity would be it can live out on the kidney because the crystal precipitates. It can lead to stones. Okay, so nephrolithiasis. So this is called gouty nephropathy. Investigations. The first gold standard is joint aspiration. There's nothing else. You have to do a joint aspiration. More than 90% cases, it will show you what type of crystals you have. But you can do x-rays, but they're not specific. Also ultrasound, they're not specific. Also, you can correlate with hyperuricemia in the blood. So they may or may not have hyperuricemia in the blood. Okay, so in acute condition, it may have elevated uric acid, but then it may go down. So that is actually not a gold standard. So remember, joint aspiration is the gold standard. So that's how you're going to approach Toronto notes, you see. And the treatment for the acute gout would be first NSAIDs. First NSAIDs all the time, remember. They can have naproxen, they can have all those like ibuprofen, everything. And if they're in high dose, and you can taper as the symptoms improve. Corticosteroid, intraarticular oral or IM. We know if they're on corticosteroids, you have to give them a PPI protection. And also IV for patients with multiple joints flaring. I'm not going to go to detail on that. And also colchicine, you have to know this. So at the first sign of attack, you can give colchicine. So until the attack has resolved, you can continue on that. And also remember that sometimes colchicine can cause some of GI issues. So you just have to make sure that you tell the patients and you do observation that how they're doing with colchicine. So NSAIDs and corticosteroids are the go-to drugs for that. Okay, so there is a pearl for 2020 American College of Rheumatology guideline. I'm sorry, this is really in smaller letters, so I'm just going to read out to you that allopurinol is preferred over all other as a first-line agent for all patients. Okay, so even you can give it for CKD stage more than 3. Okay, so that's what they're saying. Chronic gout is where you have to go for conservative and medical. So if they're on high protein purine content diet, are they on seafood like shellfish, the sardines, or any beans or peas, anything like that? Are they on that? So you have to avoid that. So avoid drugs with hyperuricemic effects. So pyrazinamide, ethambutol, thiazide, and alcohol. So here the drugs that are added are the antitubercular drug. If they're on that, they have to avoid that. And also the lifestyle modification. Okay, so if they're overweight, you have to reduce your weight, limiting alcohol intake, and these are the things that you have to look at it. And also the medical, the antihyperuricemic drugs. So first line is allopurinol. So allopurinol is not nephrotoxic. And second line is fevoxostat. So why they're different from the other drugs that you have talked about is that it decreases uric acid by inhibiting the xanthine oxidase. You always have to start low, and then you can try it up. But do not use fevoxostat if there's cardiovascular disease. So two things, takeaway things are allopurinol, not nephrotoxic, fevoxostat, always if there is no cardiovascular disease, then you can use it, and go slow and then taper. Now, there are also uricosuric drugs, so very rarely they're used with allopurinol and fevoxostat. If fevoxostat allopurinol is not working, then you can use it. So probenecid and sulfapirazine, so they're not that important. Remember fevoxostat and allopurinol. So you can always do prophylaxis, as I've told you that even a patient doesn't have a flare-up, they had a situation where they had the gout flare-up, you can always put them on a prophylaxis with low-dose NSAID or colchicine, okay, to lower the U rate. And so always remember, if there is a renal disease so you're using allopurinol, but in that case you have to monitor the creatinine clearance of the patient. Okay, so this can be a good question. The patient is on allopurinol and for say 6 months or something, and what should be your healthness promotion illness prevention advice for that patient? So you have to tell the patient, I have to monitor you with creatinine clearance possibly every 3 months to 6 months. Okay, so there is another important thing, that when you're going to use this antihyperuricemic drug, as I've told you that they're a little bit different than the conventional NSAIDs and everything, is when you see that they're having attacks more than 2 times in a year, when they have stones, when they have bone erosions on x-ray, when they have developed a tophi. So all of these are the conditions where you have to use the antihyperuricemic drug. So here's a pseudo gout. So this is a calcium pyrophosphate dehydrogenase. So pseudo gout is a again, I'm telling you that this is an this happens in old age. This happens in old age, and this is associated with hyperthyroidism, hypoparathyroidism, hypomagnesemia, hypophosphatemia, and hemochromatosis. So look at these conditions, you see. So there has to be an underlying conditions to have the pseudo gout to be developing. Okay, so it can be the old age, it can be they're having osteoarthritis, rheumatoid arthritis, hypothyroidism, hyperthyroidism, hemochromatosis, magnesemia, hypophosphatemia. Okay, so all of this can lead to a pseudo gout. So how do you remember that? You can remember that all the hypo things. So they can have hypothyroidism, and they can have osteoarthritis where they can have low magnesium, because osteoarthritis, we in naturopathy we actually also advise calcium, vitamin activity, vitamin D3, and also magnesium with it, and non-weight bearing exercise this is. So when they have osteoarthritis, presumably they have low magnesium, they have low phosphate, and there is also hypothyroidism. So all of these are there. And when you have hypothyroidism, the hyperparathyroidism is there mostly. So remember this. And also they might have chronic condition like diabetes, okay, diabetes mellitus, rheumatoid arthritis, all of this. So it's a clinical presentation, as I've told you before, that it may affect from wrist, MCPs, hips, shoulders, but less likely the joints that are involved by gout. See, the ankles, big toe, they're less likely. Okay, and presentation can be very similar to gout. And also there is also another condition if they're hospitalized. So say that they had recent surgery, and they were non-osteoarthritic patient, but they went for surgery for another condition, but they wake up one morning in hospital and saying that I have one problem, and that is my